Thank you. Welcome to New York. Many of you visiting are people from here. And thank you, Beth and Antoinette, for inviting me back again this year to speak to the audience regarding antiplatelet and anticoagulant therapy. This is an update now how we're dealing and prescribing medications from an antiplatelet and anticoagulant perspective in the cath lab. Without further ado, I have a few disclosures, none of which will affect my talk today. I will speak about non-FDA approved molecules or compounds, and I'm alert you when I do. So I want to start this talk this time with a case. This is actually a case I had about 2 weeks ago. I think it's a nice example. It's a 76-year-old female, postmenopausal female, who has controlled diabetes, hypertension, suffers from stable class 3 anginal symptoms. She's on optimal medical therapy, which in our realm means optimal anti-anginal therapy. Her primary cardiologist did work her up for this chest discomfort and was found to have on a stress SPECT maybe a moderate anterolateral ischemic defect. And she was taken to the cath lab, and you can see the images. Do we have a laser? A pointer? Oh, here it is, sorry. A significance, or a very significant proximal LAD stenosis right there. She was treated after further discussion with a cardiologist with a drug-eluting stent to the proximal LAD. And I think this is a nice case because I want to ask the audience 3 questions. And these are not the questions for the test, by the way. What? Not a test. So case 1, the first question is, in addition to aspirin, which antiplatelet should we use for this patient? There are a number of agents out there which I'll talk about, such as Clopidogrel, Ticagrelor, Pradazer, Cangrelor, a few other ones. So which one should be used and why? Number 2, and more important, should we assess her responsiveness to the antiplatelet therapy that we put her on? And number 3, how long should she be taking what we call dual antiplatelet therapy? So those are the 3 teaching points I want to talk about based on this case. So by way of review, what are the antiplatelet agents we have now available to us? Well, on this diagram, you can see this is a diagram of the platelet, and there are about 50 or 60 membrane surface receptors that are targeted by the pharmaceutical industry. Many of these you have heard about. The P2Y12 or ADP receptor, they have antagonists that block the effect of this receptor on the platelet signaling. Clopidogrel, Cangrelor, Pradazer, Ticagrelor. There are some even easier antiplatelet agents that you know. Aspirin. This doesn't work on a surface cell receptor. This works actually on an enzyme in the platelet itself. There are enzyme or a platelet receptor called 2B3A inhibitors. These are IV medications that we use less now than we did in the past, but are certainly in our armamentarium in treating patients in the cath lab. More recently, within the past year, there is now the proteasome activating receptor antagonist. This is Vorapaxar, and this is actually just FDA approved. These are all acting on the surface cell membrane receptors. So there's a lot of them. It's a kind of a name game. The question is, which one should we use? So going to probably the most tried and tested antiplatelet agent we have in the cath lab, that's Clopidogrel. You all have heard of it. You've all probably used it and have patients on it. Why do we use Clopidogrel in patients undergoing a PCI? Really, it's 2 large trials, CREDO and PCI Cure. In both of these studies, those patients that got randomized to Clopidogrel plus aspirin versus placebo plus aspirin did much better compared to placebo. So in all primary outcomes, death, MI, or stroke in both trials, there was a significant reduction in those that received Clopidogrel plus aspirin. And this is in elective PCI. Pradazer, by now, most of you have probably heard of this. It's been out for about 5 years. Pradazer is an interesting agent. It is very similar to Clopidogrel in that it undergoes metabolic activation through the hepatic enzyme pathways, but it has a more rapid onset of action, and it has a more prolonged antiplatelet action, and it's much more potent. And the description I tell a lot of our fellows is that if I gave in the audience 100 units of clopidogrel, if I gave you 100 units of clopidogrel, only 15 units are going to be available for use. 85 of those units are going to end up in the toilet. So it's not a very effective drug, and that's because it undergoes 2 steps of hepatic metabolism. Conversely, Pradazer, for every 100 units I give, 60 units will be available. So it's much more potent. It overcomes the hepatic metabolism necessary to get to the active drug. So that's why we like Pradazer. Pradazer was tried in an enormous clinical trial called Triton-TIMI 38. These are patients coming in with an acute coronary syndrome now, mind you. This is not elective PCI. And those patients that received Pradazer in yellow compared to those patients that received Clopidogrel, those that got Pradazer had a significant, statistically significant reduction in cardiovascular death, MI, and stroke that received a stent. So a very, very impressive, about a 25% relative risk reduction in primary endpoint. But it didn't come without a cost. The cost, as you well know, is bleeding. And there are 3 patients that should not get Pradazer. That's over the age of 75, a weight of less than 60 kilograms, or a prior TIA or a stroke. Those patient populations had a higher risk of intracerebral bleeding. So it's can be a very dangerous drug unless it's used in the right patient. Ticagrelor is the other agent many of you have heard of. It, like Pradazer, has a much more potent antiplatelet activation. However, the nice thing about ticagrelor, it doesn't require that liver enzyme metabolism. So it doesn't have a lot of the drug interactions that we see with clopidogrel. In addition, it binds reversibly to the P2Y12 receptor, unlike Pradazer or clopidogrel. The reason why that's important is it's quick on, quick off. That's why it's a twice-a-day drug, which actually can be a little counterintuitive for us because sometimes we have problems getting our patients to take once-a-day drugs. Now we have to have them take a twice-a-day drug. So it gets a little bit dicey after putting a stent in, having patients on ticagrelor, but by and large, they do very well with this medication. It was studied in the landmark trial called Plato. You may have heard of that. And when you look at the primary endpoint of death, MI, or stroke, those patients that received ticagrelor in yellow did much better than those patients that received clopidogrel. A 16% relative risk reduction in the primary endpoint. So very, very impressive. Again, very large trial. 18,000 patients. Again, acute coronary syndrome patients. So those patients were having an MI. The primary safety endpoint was bleeding. There was a higher risk of bleeding, but these were non-cabbage bleeding endpoints. So by and large, overall, they say the bleeding risk was not higher when you combine the cabbage and non-cabbage bleeding. So a very, very impressive drug and very, very potent antiplatelet. But the important thing is Pradazer and ticagrelor, as I mentioned, are used in patients undergoing acute coronary syndromes, not necessarily the patient population or the patient example I showed you. Cangrelor is a non-FDA approved agent. It was voted just in February, denied approval by the FDA. This is a great medication, we think, because it's a IV, parenteral administration, of a P2Y12 receptor antagonist. Why is it great? Because it has a half-life of 3 to 6 minutes. It's like adenosine. You can give it on the table, and if the patient has 3-vessel disease that you think would be better served by having coronary bypass surgery, you shut it off and they can go to the OR. So it's really important that we have this in our armamentarium for antiplatelet agents, but we're not there yet. The FDA felt like the data was not strong enough to support it. Vorapaxar, this is the other one that was just recently approved in May, just a month ago. This is the PPAR receptor antagonist. This, compared to placebo in those patients taking both aspirin and Plavix, did better in the primary outcome. However, there was a much higher bleeding risk in these patients. So Vorapaxar has higher bleeding, but improved ischemic outcomes. Where this is going to fit in our antiplatelet agents, I'm not quite sure yet. I don't think anyone does. So what about monitoring antiplatelet therapy responsiveness? Should we do it, or can we do it, and should we? Well, we can do it. We have bedside assays now to test platelet responsiveness and genetic testing, but the question is, should we do it? And if we give Plavix or Clopidogrel to everyone in this room, and we do a scatter plot of how they're metabolizing it, we find that patients or populations have a bell-shaped curve on metabolizers or non-metabolizers. So it's all across the board, ranging from people that are quote-unquote resistant, which is an old term we used to use, to being responsive to Clopidogrel. So probably 20% of the patients in this room are non-responsive to Clopidogrel. And what we previously thought was a all-encompassing drug actually does not fit all. Why is this? Why are some people not responsive to Clopidogrel? There are a whole host of demographic reasons, BMI, diabetes, smoking. There is medication interactions at the site of the liver, at the hepatic. Proton pump inhibitors was a common one that came out a few years ago. There are genetic profiles, people that have certain allelic polymorphisms that predispose them to not metabolize Clopidogrel, that puts them at risk for Clopidogrel non-responsiveness. But should we test for this? This is the ultimate question, and this was answered in a randomized controlled trial called Gravitas. Gravitas came out about 3 years ago and compared a method of testing patients with platelet reactivity versus not testing. And in the end, they found that there was absolutely no difference in clinical outcomes. So for this reason, we don't test platelet reactivity. We don't test how you're responding to antiplatelet medication anymore in the cath lab, unless we're looking for a mechanism of a problem. So elective testing does not happen anymore. In addition, should we test patients for genetic predisposition for metabolism problems? No. The routine elective assessment of genes in the cath lab is no longer done unless it's being done for an investigative purpose. So why did a patient have stent thrombosis? This may be one reason why, and it would help change our management. But by and large, if somebody has stent thrombosis, they're going to go on an advanced agent anyway. So we don't typically test for this. So I'll go to the guidelines and tell you what they tell us with regards to platelet function testing and genetic testing. Is a selective limited approach to platelet genotype assessment and function testing is the more prudent course until better clinical evidence exists to provide a more scientifically derived recommendation. Basically, it's saying, don't test, we don't know what to do with it. How long should this patient be on antiplatelet therapy? So this is always a cumbersome question, and especially in a 76-year-old female. Well, when we look at how the impact of antiplatelet therapy duration affects how our patients do, we're left with two things. Those patients that are on limited dual antiplatelet therapy, they're at higher risk for ischemic events, or the greatly feared stent thrombosis. But if you keep people on dual antiplatelet therapy indefinitely, just take it until 4 or 5 years, you're going to have bleeding. So we have to find the balance. And what we now know is that we have much better stent technology, balloon technology, wire technology, that we're finding we can shorten the duration of dual antiplatelet therapy. Maybe not a year, certainly not what used to be 3 years. And this is because of the stent design. The stent, as Antoinette told you, the stent struts are much thinner, the polymers have changed, and the healing process is more rapid now after you put a stent in. There are two trials I want to bring to your attention. One is the Prodigy trial. This was discussed in the European Society of Cardiology. This is looking at a stent platform in patients that received 3 years of antiplatelet therapy and looking at the overall death, MI, and stroke. 24 months versus 6 months. The lines are almost superimposable. So those patients that stopped antiplatelet therapy at 6 months had no difference in the clinical outcomes in those patients that continued antiplatelet therapy at 24 months. So then why don't we just continue it? Well, this is the problem. Those patients that had continued antiplatelet therapy at 24 months had a higher bleeding risk. So they bled more. So they don't actually get an ischemic benefit, and they may get harm by indefinite antiplatelet therapy. So very important study. So where are we with the evidence? Well, right now we don't have any available evidence or available evidence does not allow for a firm conclusion. We only have 1 or 2 randomized trials suggesting we may be able to go shorter for greater or less than 1 year of dual antiplatelet therapy. So therefore, we still say 1 year. There are candidates, however, where we consider indefinite dual antiplatelet therapy. And this is the algorithm. If they don't have any risk factors for bleeding, meaning they don't have an ulcer or they're not on chronic anticoagulation, and they have an increased risk for late stent thrombosis. They may be, there are certainly demographic reasons why someone can have stent thrombosis, a technical issue, a high risk stent, such as a left main stent or a bifurcation stent, or if they have stent thrombosis, it's catastrophic, and that's the left main or proximal LAD. If you have these, then you might consider being on indefinite antiplatelet therapy. But right now the guidelines tell us 1 year, but this will probably change in the next version. So the guidelines say in patients with acute coronary syndrome, patients receiving bare metal or drug-eluting stent, the P2Y12 inhibitor therapy should be given for at least 12 months. Options are the medications we discussed. This is acute coronary syndromes, so non-ST elevation or ST elevation MI. In the non-ACS, so elective PCI, that get a drug-eluting stent should get Clopidogrel for at least 12 months. You notice what's not in here. The Pradazer or Ticagrelor. Why? Because this is non-ACS. Those are medications used for ACS only. So non-ACS gets a drug-eluting stent, Clopidogrel 75 milligrams for 12 months. A non-ACS bare metal stent, we didn't even talk about bare metal stent, that's an option as well. Minimum of 1 month, but ideally also up to 1 year. So you have a lot of different variations you can use, but the guidelines actually help us a lot with this in continuing antiplatelet therapy duration. And that's it. No questions. Oh yeah. Okay. So question number 1, which of the following is not considered to be an antiplatelet agent? No music? Oh. Wow, very good. So, okay, no discussion. Okay, according to current guidelines, the optimal duration of dual antiplatelet therapy after receiving a drug-eluting stent is? Beautiful. That's correct. The correct answer is C, and in the prior question, the right answer was correctly answered with rivaroxaban. Rivaroxaban is a direct factor Xa inhibitor, which is more now, or considered an anticoagulant, not an antiplatelet. Thank you very much.